interference or feedback. So on that, it gives me a great pleasure to welcome everybody to tonight's webinar. Tonight we're very much going to focus on how we get surgical services back to some reasonable level that we all want to go and get to. And there's a number of obviously areas to consider, planning and issues that everybody wants to try and address. I want to thank anybody who sent in questions in advance. There's a great range of questions here, and I'll be putting those questions. Some are similar, and I might just push them together. But hopefully, we'll get to cover most of the topics with the speakers tonight. Tonight's speakers are a range of people who, again, will be all well known to all of us. As always, we will just open up with a few words from our president, Mr. Ken Mealy. And then we will hear from Professor Deborah McNamara, who's the National Co-Lead for the National Clinical Programme for Surgery, and Mr. Paddy Kenny, who's the National Co-Lead for the National Clinical Programme in Trauma and Orthopaedics. And we're also a great pleasure of having Brian Kinnerans, who's the President of the College of Anesthesiology, who will give us a perspective out of the anesthesiology piece on getting activity back and running. And so that's a great lineup tonight. I think there'll be some interesting perspectives. I guess tonight's focus really is about making sure we're getting our head around all of the factors and variables that need to be considered as we try and navigate our way out of the COVID-19 situation and manage services in the midst of COVID being around until such time as a vaccine is around. So on that, I'll just hand over to the President and just remind everybody that the chat function is there, and if you use that to send your comments or your queries in, we'll pick those up during the conversation and we'll put them to the panel at the end. So without any more delay, I'll hand over to our President, who will just give us an update on what's been happening in his world, I guess, for the last week or so. Thanks.
Kieran, thank you very much, and you're all very welcome. This, I think, is our fifth webinar, and we very much welcome the fact that great numbers of you join us every week, and we welcome your comments and suggestions for further topics. Tonight, as Kieran has indicated, we're going to move on a little bit, because the previous weeks we've been addressing mainly issues in relation to safety and how we support and protect fellows and members in their difficulties in dealing with patient care during this COVID pandemic. And clearly that is our primary purpose here in communicating to surgeons around the country, keeping you safe so that you can do the work that you have to do under these challenging circumstances. And before I go any further, I do want to just mention some work that has gone in the background supporting surgeons, and that is a new communication skills module for telephone consultations that has been developed by Eva Doherty and Peter Gillen and Winnie Ryan. And this is done in conjunction with our CPI and the HSE with background support from Donncha Ryan and Conor Dunphy. I think this is a very useful module and will help all doctors who need to communicate with patients over the telephone or through video links. And I think that may be one of the topics that will come up later on today, that because we have to work in a different way and probably will need to do so for the foreseeable future, telephone consultation and etiquette and keeping both patients and yourself safe under these circumstances is very important. And you can access this through M-Surgery, and it will be on our available from our website from later on today or tomorrow at least, I think. As always, I would acknowledge Erica Sullivan and Paula Mansell, who are in the background there supporting the technology for this, and Kieran Ryan and Padraig Kelly. As we've indicated, we've moved on in the sense with the COVID pandemic. As we've managed to deal with the initial crisis, there's greater challenges now in terms of how do we deal with the unmet need, with the work that should have been done over the last month or two. How do we get back into any sense of normality? And I think we all understand that the new normal is not going to be the same as the old normal. And some of the topics that will come up tonight will be, how do we process patients efficiently when we know we may need to use PPE, for instance, when we have to have greater air changes in our theatres, where we need longer cleaning regimes, for instance, between patients in our operating theatres, where we need more social spacing in our outpatient clinics. So these are all going to be challenges in getting back to what the new normal is. At a national level, we engage with the senior leaders meetings with the Department of Health, and the topic last week was getting back to normal. How do we engage with these activities, in our surgical activity in the future? The COVID-19 forum with the HSE chaired by Colin Henry, likewise starting to talk about these issues. And I know our national clinical programs in surgery are engaged with the HSE and Vida Hamilton in trying to put together care pathways and protocols. And our co-leads tonight will describe some of the work in this regard. And we will build on this in the coming weeks, where we try and model what that need will be and have care pathways put in place so that we can start looking after surgical patients again, whether that be in the public or the private sector. So without further ado, I will hand back to Kieran, and we'll get on with our three presentations tonight. And likewise, I would like to also welcome Brian Kinnerns, the President of the College of Anesthesiology, to this webinar. Clearly, the future for surgery and anesthesiology goes hand in hand, because we cannot get back to any sort of normality unless we work closely with our anesthesiology colleagues. So I'm looking forward to the discussion tonight. And at the end, because we have lots of questions, we may have some form of panel discussion regarding some of the questions that have already been submitted and those that are submitted tonight. So back to you, Kieran, and thank you all again for attending.
Thanks, Ken. That's fantastic. So again, not to delay anything anymore, we're going to hear, I guess, an update on what's going on in the National Clinical Programs for Surgery. And Professor Deborah McNamara, who needs no introduction, is going to talk to us about the surgical prioritization and the work that's going on between the National Clinical Programme and the HSE in trying to plan a prioritised and structured approach to getting surgical service back in action. So I'll hand over to Debbie now, and we'll take it from there. So I think Eric is going to put up your slides, and we'll move on from there. So Debbie, over to you.
That's great. Thank you very much indeed, Kieran, and thanks, Ken, and welcome to everyone who's joining us. I hope you can hear me okay. I think the slides are going up now. So what I'd like to talk a little bit this evening about is just a further update really on the discussions that we started last week and the last time I spoke, which is I think about 5 weeks ago now. And really the focus at the moment is on how we can restore surgical services. Next slide, please. So there's really 4 areas that I would like to cover this evening. The first is just to go through the current surgical pathway during the COVID-19 period. The second is to bring to your attention some work we've done on prioritising high priority surgeries. And this is covering the areas that are under the remit of the NCPS. The third is to introduce you to the work that's ongoing between ourselves and the HSE and the College of Anesthesiologists and other colleagues about how we can resume surgical practice in a safe way. And then just a final slide in update of other activities. Next slide, please. So I showed you this diagram on the last occasion, and this is really the defined pathway for surgical patients at the moment. The green box in the center being the surgical patient who still presents principally through their GP or to the emergency department. And for the period of this pandemic, we've had a number of differences from usual. So we might move on to the next slide just to highlight some of those. And they're marked in red here. So we've introduced a GP Surgeon Connect phone line, and thank you to all of the surgeons who are participating on that in a voluntary capacity. And that enables GPs to contact a surgeon directly to get some further information about how they might manage a patient in the community or how they might access services without requiring the patient to go to the emergency department. We've had really strong feedback from our GP colleagues that this is a highly valued resource to them, and we're very grateful to the team in our CSI who got this up and running so quickly. It's been running for more than 3 weeks now. So another difference from our usual way of doing business is outpatients, and in many hospitals, routine outpatients departments are not happening. It has been requested by the HSE that we would begin to actively manage all surgical outpatients, and many surgeons around the country have already been doing this. Each week reviewing the list of patients who are due to attend the clinic, deciding if it's something that can be dealt with by a virtual consultation by phone or using telemedicine. Perhaps simply a letter can be sent to a GP with a result if that's what's required, or perhaps the patient can be referred directly for an investigation instead of attending hospital for an outpatient visit. On the RCSI website, we've placed 2 resources specific to this in relation to, firstly, how a remote clinic can be run, or how a virtual outpatients clinic can be run safely. And secondly, we have a document that gives some guidance as to how outpatients could be triaged. So that's something that I would encourage you to have a look at if this is something that you need assistance with in your own practice. And then separately from that, we have consistently since early March highlighted the necessity to have urgent surgical elective capacity for scheduled surgical care, which is urgent but not necessarily emergent. And that has been very challenging in many hospitals, with surgical activity greatly reduced. And I'm going to focus on that next. So next slide, please. Our group in the National Clinical Programme in Surgery, and in particular our clinical advisors and the specialty chairs, have all submitted information about what surgical conditions represent high priority operations that must happen to avoid patients coming to harm because of the delay of their treatment. So we are particularly concerned that while COVID is a very significant risk to patients at the present time, it's very important that patients aren't coming to harm because of the absence of surgical services. Next slide, please. So this guidance has gone live on the RCSI website today, and it's a document compiled with the specialties that you can see listed. I'm not going to go through each of those areas, but I think it's important to note that we've worked closely with the NCCP on this in areas relating to cancer, but there are many other areas that surgery is urgently required that aren't cancerous, and that's something as a college we've always tried to recognize and to encourage the health system to identify. So I suppose thinking of examples in neurosurgery, a number of examples in relation to cardiothoracic surgery, and similarly in the area of pediatric surgery like cleft surgery. These are all benign conditions, but naturally have a very significant impact on patients. So it's important that our prioritization does not exclusively focus on cancer, although of course cancer is an important part of it. There is some further guidance on our own website about the cancer area, and also the NCCP website for surgeons who are interested. Next slide, please. So as we try and get things up and running again, there are probably 3 separate pathways that are very relevant to surgery, and each of these pathways needs to be operational for patients to get the surgical services that they need. On the top line, I've highlighted the ones that are relevant to the public teaching hospital environment. So there will always be complex surgery that can only be performed in our academic teaching hospitals or in our larger Model 4 hospitals. A very small minority of patients with COVID may require surgery, although that is to the greatest extent possible avoided. But there is quite a lot of complex surgery that must be done in this environment. And so it is necessary that in our major hospitals, we will design pathways that protect patients from the risks of having an operation while being asymptomatic for COVID, and equally from acquiring COVID while in the hospital. So there is still a great deal of surgery that needs to take place in our large hospitals, and that's very challenging because they are still dealing with reasonably large numbers in some hospitals of COVID cases, and in other hospitals a diminishing number. On the bottom of this table, there is a great amount of low complexity surgery that's highly suitable to be done in different sorts of environments. And while we need to recognize complex surgery, it's really important that we recognize that there's a lot of surgery that can very safely be done in smaller public hospitals and in the private hospital environment. And we need to operationalize pathways that enable patients and surgeons to operate in these environments to start doing low complexity surgery. And very importantly, this covers a lot of diagnostic procedures. So things like cystoscopy, things like laryngoscopy, gastroscopy, bronchoscopy, colonoscopy, and all of those procedures are highly suitable to some of our smaller hospitals. And particularly in hospitals where COVID is not as much of a challenge at the present time as it is in some of our other hospitals. Next slide, please. From the patient perspective, in relation to scheduled surgery, there is a great deal of fear. And part of what we must do is rebuild confidence in the health service so that patients know that they will come and receive a safe service. And for a patient, really, there are two important aspects of that. Firstly, we need to make sure, insofar as we can, that patients are COVID-free at the time they have their operation. And secondly, we need to guarantee, in as far as we can, that a patient does not acquire COVID during their hospitalization. Next slide, please. We're in a rapidly changing circumstance, but there is clear evidence that patients who undergo surgery while COVID positive experience worse outcomes. And there are series that all surgeons will be familiar with, particularly one published in Lancet Infectious Diseases, indicating high mortality rates among patients who underwent an operation while COVID positive in an undiagnosed way. In other words, patients who were asymptomatic and where either they were not tested or their testing did not reveal the presence of COVID. We cannot eliminate that risk, but we can minimize it. Over the last 2 weeks, we've worked closely with Dr. Vita Hamilton, who's chairing a subgroup for the expert advisory group that reports to NEFIT. And there are a series of HSE protocols that are nearing completion that have been circulated for stakeholder feedback. And these will cover many of the important areas and a lot of the questions that surgeons have raised during our webinars and in other contact with surgeons. The solution that's going to be put in place to try and manage this patient perspective, I suppose, firstly, is going to recommend some preoperative cocooning for patients, because that 14-day cocooning period reduces the risk that the patient has asymptomatic disease. The majority of patients who are going to become symptomatic do so within that 14-day period. There needs to be preoperative COVID testing, and that needs to be proximate to the time of the operation, and there needs to be systems in place to enable that. As the President mentioned, there is a strong need for physical distancing measures to be taken in our hospitals, and that's going to lead to very substantial changes in patient pathways and flow that will have a significant impact on the capacity of our health service. That physical distancing is necessary, but we also need to have strong infection prevention and control measures, advising patients about all the simple things like hand hygiene, wearing masks, and staying away from other patients. But equally, one of the points that the surgical program have emphasized very strongly is that we absolutely must have ring-fenced surgical wards again. It's not acceptable that we would have surgical patients cocooning for 2 weeks prior to surgery and then placed post-operatively on a ward that's mixed with patients who have been admitted directly from the emergency department. It isn't reasonable for patients to have gone to such precautions and then be exposed to the risk of acquiring COVID from another patient. And of course, it requires that we have healthy staff, because healthy staff reduce the risk of the patient acquiring COVID while in hospital. And that's about having policies in place around wearing PPE, testing of staff as needed, and having strong occupational health policies so that staff who are symptomatic or have temperatures are identified and are not working and risking passing the disease on to patients. Next slide, please. We have also tried to emphasize the surgeon and surgical team perspective in these discussions. And from the perspective of the surgeon and the surgical team, clearly the critical issue of PPE is very important in protecting us and our teams from acquiring COVID in the course of our work. Reducing the prevalence of COVID in the community goes a long way towards reducing that risk, but it's also important that we minimize doing procedures in COVID patients. And a lot of the factors that relate to the patient factors are working to address and minimize that risk. Next slide, please. From the perspective of the surgeon and the surgical team, the HSE guidelines that we anticipate will be issued next week will focus on the importance of hand hygiene, masks, and physical distancing for standard work. But one of the points that we've emphasized strongly is that the PPE strategies must be based on safety of staff and not on a rationing or availability issues relating to PPE. If we are to resume scheduled surgery, we must be in a position to provide the PPE that is required for staff to remain safe and to follow the protocols that are put in place. So in getting surgery up and running, obviously the lockdown period that is ongoing has done a great deal to reduce the prevalence of COVID in the community. There is great variation around the country in the prevalence of COVID, and it's likely that activity in hospitals will scale up and scale down depending on the prevalence of COVID in their local area. We need to be prepared for that. When COVID prevalence is low, we need to increase surgical activity because it is possible that there will be further peaks in COVID, and it is simply not sustainable that surgical activity would be stopped completely nationwide every time something like that happens. We need to screen carefully and ensure that the patients that are scheduled have the lowest possible risk of COVID, while understanding that at present there is no mechanism that completely excludes the possibility of COVID. For surgeons, I suppose the issue of PPE in theatre is particularly important to us. And what we have requested is that the guidance that is issued should always leave space for the surgeon to exercise judgment. It's clear that some procedures are very high risk for aerosol generation, and we've heard a lot from our head and neck surgery colleagues about that. There are some procedures that are lower risk for aerosol generation, and then there are some procedures where it's very, very uncommon that an aerosol would be generated. But it's simply not possible for someone to issue a guideline that will cover every single aspect of our specialties. So there must be space for surgeons to make an assessment of their risk based on their expertise and taking into account the most recent society guidelines of their specialty, so that they can elect to increase the level of PPE in situations where they believe that is a necessity. Next slide, please. So in getting back to normal, we need to focus at the same time on the public teaching hospital environment and in the public or private hospital environment where we might do more intermediate surgery. In the teaching hospital environment, where most of the major complex surgery is likely to take place, we need to work to increase the volumes of surgery that can be done while accepting that there are significant capacity constraints, and while very much recognizing the challenge that our anesthesiology colleagues are facing in dealing with COVID patients in the intensive care and all of the changes that are happening. We are recommending that surgeons consider and review the pathways of care that are available in their big hospitals so that they can decide how they can best increase activity. It is possible for some major surgery to be transferred to the private hospital environment, but this very much depends on the capacity of the private hospital to deliver the same sort of care. Working with the NCCP, we've recommended that decision making would go through MDTs when it relates to cancer surgery, and the NCCP have issued some guidance on that subject. So we think that there is a need for constant work to try and increase the number of operations that we can do in the major hospital setting. It's important to note that around the country there isn't equal access to private hospital sites for every hospital group. So hospital groups need to be free to design solutions that will use all of the hospitals in their region. We would very much try to move away from the idea that only private hospitals can deliver low complexity surgery. There are smaller hospitals, Model 2 and some Model 3 hospitals all around the country that can very effectively and safely deliver very high quality surgery to a large number of patients. And we need to encourage local hospital groups to design those solutions. And in starting to get things working again, it seems likely that we will need to start with procedures that are based on sedation or based on local anesthetic and get those systems up and running, and then work in local hospital groups with our anesthesiology colleagues to see how we can assess the capacity to deliver more surgery in each hospital group, taking into consideration the prevalence of COVID at the time. Next slide, please. Just to draw your attention to some of the guidance that's available on the RCSI website, where we have been updating daily, and also the NCCP website and the HSE guidance documents are likely to come out next week, which I think will be very useful. Again, just to thank those who are taking part in our GP Surgeon Connect line. Next slide. I'd like to very much acknowledge the contribution of so many people who've supported in developing all of this work over the last number of weeks. A large number of people have contributed to this work, and I'm very grateful for that. If there are issues that we can assist you with, please do get in touch. And the last slide just has some contact details if you need to get in touch with us. Thank you very much, and I'm more than happy to take questions. Thank you.
Debbie, thanks a million for that. Really comprehensive, and congratulations on getting the guideline document out on prioritization for surgery today. The timing just couldn't be better. So I'd say, have you slept at all in the last 3 or 4 days? I don't know, but well done to you and all the team in getting that out. It'll be very, very useful following today's webinar. We'll take questions at the end, and I'll put those to the panel with different discussion points. And I think you covered a lot of the questions that I see have come in to us prior to the webinar, but I'll put them to you anyway, because there'll be interesting discussions. So to move on then to our next speaker, it's a great pleasure as well to welcome Mr. Paddy Kenny. And Paddy, along with Mr. David Moore, are the national leads for the National Clinical Programme in Trauma and Orthopaedics. And they're going to talk to us about the T&O recovery plan and what's been going on there. So Paddy, I'll hand over to you, and then Erica will put up the slides as you go through your talk.
Thanks very much, Kieran. Can you hear me loud and clear? Yes?
Yes, Paddy, can hear you all right, yeah.
Yeah, thank you very much, and thank you very much, Debbie. You can put up the first slide, Erica, please. My job this evening is to give an update on what's been happening in trauma and orthopedic surgery. And I think that I will probably throw up more questions than answers. Some of those questions Professor McNamara has answered, and more of them hopefully will be answered by the new guidelines from the HSE, which are, as Debbie says, are due to come out next week. The next slide, please. So normal is a long way from here, and even if we get back to where we were, are we back to normal? We had a lot of problems with our service before the current crisis, and we have learned a lot so far with this, with the crisis, and with the way we have been trying to manage it. The next slide, please. So the reintroduction of elective surgery presents the following risks: an increased burden on ICU, and Professor McNamara has mentioned some of these things. The graph on the right is a snapshot from last week showing that at least 6 of our intensive care units in our hospitals are under extreme problems with bed occupancy, over 100%. Connolly Hospital is almost 250% at one stage last week. There's also an increased risk of infection and hospital-based outbreaks, as Debbie mentioned, an increased burden on PPE supplies and on the testing regime. The next slide, please. So as Debbie mentioned, prioritization from an orthopedic point of view, we still need to prioritize, and the patients that we especially need to prioritize are trauma patients, patients with infection, oncology, neurological compromise. A lot of our patients are in extreme pain, patients with imminent fractures that need revision surgery, pediatrics and time-dependent surgery. So prioritization is still necessary and probably more important now because a lot of these patients have been waiting for 5 weeks or more longer than they needed to. The next slide, please. So some of the stuff that we have been doing, and the reason I bring this up is because I think it will move into the future for us. A lot of our trauma patients have been treated in hospitals which traditionally haven't treated trauma, such as Kappa Hospital. The South Infirmary in Cork has been doing a lot of trauma surgery, and it's usually a purely elective hospital. St. Vincent's have been sending a lot of work to St. Vincent's Private, and other hospitals around the country have been doing some of their trauma work in sites that they don't usually do it. Our local injury units have been very busy. And one particular thing that has come out of the current situation is our use of the Silo app. Some people may not be aware of the Silo app, but it's a secure medical messenger app, which prior to this time was used a lot by the orthopedic department in the Mater Hospital. And now a lot of us around the country are using it. It's a secure messenger, so patients' data and x-rays can be sent over the app. And it means that the emergency department personnel can get an immediate response from an orthopedic consultant when they have a patient in the emergency department. And the decision is made immediately as to what treatment that patient needs. At the moment, the patient, a typical example would be a patient who would present with a fracture. They'd be put into a splint. The advice would be to go home and represent to Kappa Hospital maybe 3 or 4 days later, when there will be a surgeon there and an operating list for them to do their operation. So it makes our patients that we previously used to admit straight into the ward now go home possibly for 2 or 3 days and get appropriate treatment by an appropriate surgeon in an appropriate hospital. As you know, the trauma report recommends that there will be 3 trauma hospitals in Dublin. And I think this Silo app system that has been developed during the crisis will be essential to making that happen. The next slide, please. When restrictions are slowly lifted, there will definitely be an increase in trauma. We're heading into the pediatric fracture season. There'll be staff problems. A lot of theatre staff, as we know, around the country have been redeployed into intensive care. And we've always competed for resources, but I think the competition will be even more intense when we try to get back. Next slide, please. So with regard to the outpatient service, Professor McNamara has already mentioned telemedicine. There is active work going on to provide telemedicine to the outpatients departments. Face-to-face meetings will, I think, be less common, except for over the tele-link like this. Social distancing in waiting areas, PPE policies, COVID testing, waiting list. Professor McNamara has mentioned some of these. To get over the backlog, we may be looking at extended working days and weekends, which of course will bring up HR and industrial relations issues. Next slide, please. So with regard to the outpatients, we already have a trauma assessment clinic system, which is used in many of our hospitals, and that is a virtual triage service, which has been very successful in the hospital that it's in. Video link telemedicine, I think, will be something that we will be using a lot of for pre-op counselling, post-op review, and also for the National Joint Register. In the last few weeks, very few of our patients, or none of our patients, have received their National Joint Register review, and I think in the future a lot of that will be done over the airwaves. However, we have problems in all our hospitals with software, hardware, with Wi-Fi. Patients have problems with Wi-Fi, and it will bring up issues of record keeping. We run MSK clinics, and perhaps a lot of that could be done by telelink, and the virtual clinics, which we currently are doing because of the COVID crisis, I think we will continue to do as we move into the future. Next slide, please. So with regards to the outpatient services, this is a photograph from the Blanchardstown outpatient clinic, and I think this situation we won't be seeing in the future. It's unsatisfactory. I think we will never again see fracture clinics where we have 100 patients waiting in the waiting rooms. With regard to social distancing, I think we need to know who's going to accompany the patient. I think people will and should be discouraged from bringing their children to the clinic. Patients will have to get appointment times and stick to their appointment times. Currently, what happens in the orthopaedic fracture service, or indeed in the clinics, is everybody turns up when the clinic starts. But I think people will have to stick to the time of their appointment and be seen at the time of their appointment. And also, I think they'll have to get an appointment for an X-ray if it's determined that's needed prior to coming to the clinic. And this will decrease the amount of traffic. With regard to PPE, there's recently been a guideline from the HSE saying that all medical staff in clinical areas in contact with patients should wear face masks. Well, we don't have guidance as to whether the clerical staff need to wear face masks or whether patients need to wear face masks. Appointments will take more time and therefore we'll need more staff. And as I previously mentioned, I think we'll need an extended working day. Next slide, please. It's imperative that patients don't get lost in the system, and it is quite possible. We need clear records of patients who are deferred, and in that way we'll be able to plan for what's going to happen next. And of course, as we know, it's inevitable that waiting lists for both outpatient and surgery will increase. Next slide, please. So patients need clear messaging about the risks and implications if they're coming to the hospital, whether it be to outpatients or for a procedure. The consent issue needs to talk about COVID. Many hospitals have COVID-free and COVID-positive pathways, and many hospitals, most hospitals I think, have COVID-free and COVID-positive wards. But as Professor McNamara mentioned, do we need to have COVID-free hospitals and COVID-positive hospitals? And I think we probably do. As she said, it will be up to the local hospital groups to decide how they will use their local hospitals, but I think it makes sense that there should be separate hospitals. I think there'll be difference to our day of surgery admissions, probably more day of surgery admissions, as people will be less inclined to be spending the night before their procedure in hospital, and it may influence our average length of stay as we may discharge people quicker to get them out of the hospital environment. Again, Professor McNamara mentioned pre-op screening issues, and of course we will need visitor policies. The next slide, please. So in the orthopedic world, we have 6 standalone orthopedic units, elective surgery orthopedic units, although the South Infirmary also does a lot of surgery apart from orthopedic surgery. But it seems to me for us to get back to elective surgery, these are the ideal places that we should start. CAPA, the National Orthopaedic Hospital, is currently doing a lot of fracture work and running 2 theatres every day. But from next week, we're going to probably be running 3 theatres a day, and the 3rd theatre will be for urgent or semi-urgent elective work. These 6 hospitals are very well run, very efficient, and I think it's an ideal location for us to start back with elective surgery, and not just orthopedic surgery. I think that it is quite possible and should certainly be considered that these hospitals, which hopefully mostly will be COVID-free hospitals, should be able to do some low acuity general surgery and other surgery as well. Next slide, please. The next slide again, please. So as Professor McNamara has read all of these documents, and it is influencing what is going to be the guidelines for the document coming out next week. But this document is a roadmap for resuming elective surgery, which comes from the American College of Surgeons in association with the American Society of Anesthesiology, the American Hospital Association, and the Association of Perioperative Nurses. And they say there should be a sustained reduction in the rate of new COVID cases in the relevant geographic area for at least 14 days. I'm not sure that we have that yet. Facilities should be able to should use testing to protect staff and patients where possible, and should implement a policy addressing requirements and frequency for testing. I don't think we have that yet. And the facilities should not, as Professor McNamara mentioned, we shouldn't resume elective surgery until we have appropriate PPE. Next slide, please. This is the last version. The new version is coming out next week of the Health Protection Surveillance Centres document. It's an old document. It's 3 weeks old, the 8th of April 2020. Next slide, please. But it suggests that the decision for surgery is essential. The decision that surgery is essential during the period of infectivity should be made by senior surgeons and anaesthetists. Importantly, for orthopaedic surgeons, and I don't think this is going to change in the new document, ventilation in both laminar flow and conventionally ventilated theatres should remain fully on during surgical procedures. There should be a minimum amount of staff in the theatre. Next slide, please. The patient should be reviewed, anaesthetised, intubated, extubated, and recovered in the operating theatre, appropriate PPE. And if the procedure is anticipated to involve aerosol generating particles, then all staff should be wearing the appropriate PPE. Next slide, please. Most orthopaedic procedures are aerosol generating procedures, and I think that certainly from an orthopaedic point of view, we should be using significant PPE. The next slide, please. So at the moment, the recommendation for aerosol producing procedures from an orthopedic point of view is that you wear an FFP2 mask, goggles, the blue balaclava, and a face shield. Thank you. Next slide. Thank you very much. I think we are a long way from getting back to normal.
Paddy, thanks a million for that. Very, very comprehensive and very, very concise and understandable. Lots of very good pragmatic solutions and guidance there. And it's also good to see that everything is very well aligned, I think, all across our clinical specialties. And so, as the President mentioned earlier, clearly this is a team sport we're all involved in, and we have to bear in mind all the other people that we have to work with. And it's brilliant to have the President of the College of Anesthesiology presenting the perspective on getting activity back up and running, because it's going to be a vital part of getting elective surgery, scheduled care back in action for everybody. So Brian, I'm going to hand over to you now to hear from the perspective from anesthesiology. Thanks.
Thank you, Kieran. And could I have my first slide, please? And whilst the slide is coming up, it's perhaps an opportunity for me to thank Mr. Kenneth Mealy, who invited me to contribute to the webinar. And I'm very happy to be here and to do so. I'm very conscious that lack of surgical access may result in a reduction in therapeutic options for our patients, and that may ultimately result in suboptimal outcomes. In other words, that patients may come to harm as a result of lack of access to elective surgery. Can I go back to my first slide, please? I'm also conscious of the fact that as a college, the absence of elective surgery limits our ability to deliver our training program. So there's a synergy in terms of the two pieces. Could I have my next slide, please? We have been here before. This is a physician of the 17th century. This is the plague. The conical mask you see worn would have been filled with herbs to prevent the physician from inhaling the miasma or the bad odors associated with the plague. And the stick was used to examine their patients from a purportedly safe distance. Could I have my next slide, please? So a lot of the planning for COVID-19 was about delivering surge capacity, particularly within the critical care community. And I'm conscious that before we had our first patients, elective surgery had stopped to allow for education and training of a wide variety of healthcare specialists in the critical care environment. So the mantra really was about capacity planning and critical care surge planning specifically, with the view that once this is over, we will move on. But it's fairly clear to all that now COVID is here for the foreseeable future. And we have referenced the word normal. Until we have a vaccine, we will not be returning to normal. There will be, as many speakers have alluded to already, a new normal. Could I have my next slide, please? So obviously, in terms of the new normal, one of our challenges, of course, is that we need to devise both a pathway for our COVID patients and a pathway, of course, for our non-COVID patients. And in terms of last Saturday's NEFIT meeting, it was specifically focusing on planning for the non-COVID pathway. My sense is that the surge capacity we will need is probably going to be on the non-COVID pathway rather than the COVID pathway. And of course, our challenge for the future is to provide a safe COVID pathway for our patients. Next slide, please. What we have learned from London, from New York, and indeed Dublin, is that COVID-19 is a metropolitan disease. And whilst I accept that in terms of the re-establishment of elective surgery, we do need a national framework that oversees this. Local solutions, that's to say what works in Tala, will not necessarily work in Tullamore, may be applicable as well. And I think the Model 3 hospitals, specifically given their limitation of critical care beds, reassumption of elective surgery will be particularly challenging. Could I have my next slide, please? So this is data up until about mid-April from NEFIT. And really, it shows in blue the cumulative number of cases, and in red are the cases that have admitted to ICU, and the black line, of course, represents cumulative deaths. And I'm showing you this slide largely just to emphasize, of course, that from about mid-April, this curve has been flattened thanks to the action and efforts, not only of healthcare professionals, but also of the national population as a whole. Could I have my next slide, please? And in terms of deaths, we seem to have peaked around mid-April. Having said that, there was a spike last night, but by and large, the trend in deaths is reducing. And as of from today, we have had over 1,159 deaths. Specifically in terms of ICU, and could I have my next slide, please? This represents admissions to our ICUs. Now, at the start of this pandemic, Ireland had approximately 250 critical care beds. This is one of the lowest number of critical care beds in the OECD. And our surge capacity doubled the number of beds. And we did this, of course, using the resources from the elective service. That is to say that nurses from both theatres, from the anesthesia section of theatres, and also from recovery, were actually upskilled and trained in terms of critical care. we currently, in terms of the overall pandemic, about 1.9% of our patients seem to require ICU. And in our ICUs throughout Ireland, 326 patients who have had COVID have passed through our ICUs. The average length of stay is 10 days. And as you can see from this graph here, the demand for ICU beds seemed to peak around early April. And there has been a sort of a gradual reduction in ICU requirements since then. The figure for today is that there are 125 patients in ICU. There were 131 yesterday, and of that 125, 81 are ventilated. However, it's probably worth pointing out that this represents half of the baseline ICU capacity in our system. And the only way that elective surgery can actually take off is that these additional resources which were allocated to critical care have to be repatriated to recovery and to the theatre complex. Additional capacity in critical care is a necessary element to the absorption of elective surgery. And many of you may have seen a document which is sent out from the college with the other respective partners about the need for Ireland to increase its critical care capacity. And we would see this as being a very important part of opening elective surgical services. Could I have my next slide, please? So the NPHET now finds itself in a fairly delicate position insofar as it has to counterbalance the society's requirement to lift some of the restrictions versus the common good in terms of reducing the prevalence of this disease. And could I have my next slide, please? And whilst nobody wants to talk about this, it is important that we address this issue of the so-called second wave. My next slide, please. This data is from the Philip Nolan's group, which is the Epidemiological Modeling Advisory Group. And what he's done here is he's actually modeled what a lifting of some restrictions will do to the reproduction number, or the so-called R number. And all his modeling calculates that there will be an increase in cases presenting to hospitals following lifting of some of these social restrictions. So on the y-axis here, you've got new cases per day. So currently the R number is 0.54. If this R number increases to 3.7, we will have 12,000 new cases presenting per day to our hospitals. On a more modest level, if our R number increases from 0.5 to 1, then by midsummer, we will have close to 400 patients per day presenting to our hospitals. If, however, we do better and the R number is less than 1, 0.8, then by midsummer, we will have approximately 40 patients per day presenting to our hospitals. So this emphasizes the fact that the lifting of restrictions will probably produce an increase in activity in our critical care and our hospital communities in general. Next slide, please. Some of you may have seen this. This is a document produced by the American College of Surgeons, specifically in relation to how one would reassume normal elective surgical services. And could I have my next slide, please? And this was a joint statement which was referenced by Mr. Paddy Kenny in his previous presentation. And this is a joint statement, as he said, between the American College of Surgeons and the American Society of Anesthesiologists. And this is actually quite a good document, which I would actually recommend for your use. It does outline the steps that would have to be taken in order for surgery to be resumed. My next slide, please. Similarly, this is a joint statement, in this case by the Australian and New Zealand College of Anaesthetists and the Royal Australian College of Surgeons. about the resumption of elective surgery in Australia, and this was posted on the 21st of April. This may in part reflect the fact that Australia seems to have been spared some of the actual prevalence that we've experienced in Europe. Next slide, please. So in terms of the college, what are we doing? At the behest of Vita Hamilton, the National Clinical Program for Anesthesia, which is led by Dr. Jeremy Smith, who many of you know, has been formed specifically to look at this particular issue of the resumption of elective surgical services. And again, we're pleased to have on this committee Professor Deborah McNamara, who represents RCSI. And I think this group's been tasked with developing a framework that will allow for the introduction of elective surgical services. Could I have my next slide, please? So I think the resumption of surgery is largely about the who, the how, and the where. The who, of course, represents the piece around surgical prioritization. The how is the piece around protecting our patients, and the where represents the piece around complexity and using both the public and the private sector. I think there are three pillars that will allow elective surgery of health that we need to test and have a robust method of testing and understand prevalence. And that's not just national prevalence. We need to understand regional prevalence in relation to when it's safe to recommence elective surgery. The pillar on the right represents, I think, timing and capacity. And it was referenced previously that there has to be a sustained reduction in the number of cases presenting, or at least 2 weeks prior to commencement of elective surgery. Capacity relates to issues such as having the capacity to have 2 defined pathways. And I think in the Model 3 hospitals, having an intensive care unit with a limited number of beds, that will prove to be challenging. Capacity refers to the diagnostics, and capacity refers to theatre capacity, and more so, of course, importantly, is the human resources. The pillar in the middle is the piece that keeps the edifice up, and that, for me, represents consensus and collegiality. And I think as colleges, we have an opportunity to provide leadership in how we see the resumption of elective surgical services. Thank you.
Ryan, thanks very much. That's, again, superb range of information and understanding of your perspective on these things. So at this stage, we tend to get into a bit of a conversation with the panel, and hopefully everybody can stay online. As always, if everybody just keeps their microphones on mute, except maybe the panel members who can come in on the various questions. So maybe to kick off, I might ask both, say, Debbie and Paddy, just on the guidelines that have come out there for the prioritization of urgent scheduled conditions, would you maybe just give us a few minutes on how that document came about and the information behind it and how it was devised as such, and that it is indeed a guide and perhaps there's some local flexibility needed on these areas as well. So maybe Debbie, you might just give us a few comments on that.
Sure. So this guide's we started developing it in about mid-March, and it began with the clinical advisors in the NCPS. So we have clinical advisors in a lot of the major specialties. We reached out to surgeons in areas where there aren't clinical advisors. So this came from each specialty group, and a lot of people listening tonight will have been involved in webinars or conversations or phone calls that were around how we would prioritize. I'd take the example of the urology segment. We're now on the 3rd iteration of it. And Professor Eamon Rogers has been working with his colleagues to keep refining it, because I think Paddy mentioned earlier, 3 weeks is a very long time at the moment. So frequent revision has been part of it, and we published what is available on the website today, but in another couple of weeks there may be some further additions that are needed.
Yeah, I think that's fair, isn't it? It's just such an ever-moving situation for all of us right now, and as you said, 3 weeks. It's a bit like that saying, a week is a long time in politics. Well, a week is a long time in surgery right now. So it's all changing very fast on that. Paddy, do you want to say anything on the approaches there?
Well, not really, Kieran, except that we haven't been involved with the same group that Deborah is involved with, but we have, with Catherine Farrell as our program manager, we've been developing our own list of, and they're pretty obvious in orthopedics, you know, what needs to be done, and so we've developed those ourselves, and you know, everybody I think will agree with them and adhere to them, because in orthopedics it's pretty obvious what needs to be done.
Okay, well, Paddy, while I have you there, just one of the kind of questions come in, and I think you've probably covered a bit in your talk, but it's worth probably hearing what you think. Someone asked the question: can we ever see ourselves returning to a traditional fracture clinic?
Nobody wants to ever see a traditional fracture clinic returning. 120 people fighting for seats and knocking each other over and maybe getting more fractures. Hopefully not. But on a serious note, the trauma assessment clinics that we have up and running for in Tullamore under the guidance of Mr. Owen Sheehan, and Owen has been rolling it out throughout the country. That's been ongoing for 2 or 3 years now, and it's a fantastic resource, and that alone has decreased dramatically the number of people that attend the fracture clinic. This new silo app system that we're developing will again dramatically decrease the number of people that need to come to a fracture clinic. And I think the answer is no. Hopefully we will not see the traditional fracture clinic again.
Great, thanks for that. And I suppose on a related matter then, I mean, that's the TNO perspective. Debbie, as regards outpatient clinics for all the other specialties, I mean, what do you see as the main kind of challenges? You mentioned things like social distancing and maybe the length of the day and all that sort of thing. What might be needed to rethink how we approach the outpatients?
So there's an enormous piece of work around how we restructure outpatients. I suppose our waiting rooms are going to be redundant. We're going to have fewer family members and people accompanying patients. In some hospitals, the infrastructure really doesn't support proper social distancing. We will need to move to seeing fewer patients at appointed times. And I think to the greatest extent possible, we should be stopping the majority of outpatients coming to hospital, except for the most complex cases and where we can bring patients in, give them an appointment and see them. So I think we couldn't underestimate how much work is around that. There has been quite a lot of work done on that with Professor Colin Berg, and it has written a document, which is really an excellent document just to give a framework for how outpatient services will develop. So there are people thinking about this across the system, but it is a really tricky one.
Okay, thanks. We did an interesting question, and I think many of you mentioned in your talks the whole area of testing and antibody testing. And are you aware of any plans or the approaches or the advice that we might be having to give to the HSE and service policymakers around testing and antibody testing for healthcare staff, or indeed the testing requirements for patients? And I think, in fairness, in your steps there about the pre-op cocooning, the pre-op testing, all these are very vital parts of the safety process. But any updates on what the thinking of the services are on that at the moment?
I just say in many countries, Kieran, what they have shown is the more testing you do, the more knowledge you have of the disease and how widespread it is. And we have a capture population in our patients that are coming in. So my view would be that they should all be tested. And I also think another point is, should we have a system that healthcare workers get regularly tested?
Just to add to that, I think there has been some work in this area. the advice that healthcare workers should wear masks while interacting with patients was part of that, in the hope of reducing transmission to patients by healthcare workers. Some of the new guidance may suggest that temperatures of healthcare workers may be taken on arrival to work, and that's something that's moving along. The difficulty really is that there is no test that proves you don't have COVID, and of course that's the question we all really want to know the answer to. And I suppose at the moment the understanding on antibodies seems to be that although they may be present, it's not clear if that renders a person immune to COVID. So I think there's a lot more to learn on that area.
Thanks. I might just an interesting comment there on the chat is the whole area of a lot of nursing staff have been redeployed to different parts of the hospital, and as we try and get a recovery back to a return to surgical services, what level of involvement are nursing having? Have you seen maybe Debbie at the national level in planning around that?
So, I mean, nurses have been integral to all of the planning. At the moment, we're really still in crisis mode, and we can't start services unless we have proper nursing ratios. And I think that was the point I was trying to make when I talk about the surgical team, because it's not just about surgeons and anaesthetists. There's a whole range of other members of the team that we have to deal with, and I think the ITU expansion in bed numbers sucked up staff who are not primarily ITU nurses, and ITU nursing is really a highly specialized area. So I think while it's very, very welcome that we might increase ITU beds in the future, I mean, obviously, Brian might have something, more to say on that point. Obviously, nursing is going to be critical to getting things up and running.
Yeah, thanks. Because I think the webinar next week, or we're planning at the moment, I think we're going to start involving perioperative nursing on that as well, to get that perspective, and because getting the planning around this, and I guess some of the detail is going to be vital. And Brian, you mentioned actually during your talk that the surge could really be coming from the non-COVID pathways with everything that's backing up, and that probably relates to that point about the redeployment of staff, getting them back, and what levels and staffing levels we might need if we're looking at longer days with slower lists and so on. We may need to be looking at more staff that are going to be required. Do you want to expand more on that idea that the surge could be in the non-COVID patients later?
Can you hear me, Kieran?
Yes, Brian. Yeah.
Okay, so thank you. Could I just backtrack just to two pieces? One is a bit just to add to a bit about the testing. This was a sort of a discussed at NEFIT 2 weeks ago, and PCR remains the standard reference for testing. The antigen and antibody testing are both experimental, and they will need clinical validation trials, so they won't be happening for the time being. And I think the testing thing, as Debbie said, really all you can say is whether you're positive. You can't necessarily say you're negative, but I think that's part of a suite of interventions, risk of which cocooning questionnaires and testing are part of that.
Yeah. So, Brian, your connection is a little bit breaking up a little bit at the minute. Do you want to try again there? Okay, Brian, we might come back to you. Paddy, you wanted to come in there on that, did you?
I just wanted to make a comment. I think that we, and hopefully have seen the end of agency nursing, because we can't have nurses going changing hospitals or working in a nursing home one day and coming to the hospital the next day. So, and if we have to end to agency nursing, obviously we need more nurses.
Yeah, that makes a whole lot of sense. Paddy, while I have you there, and Brian, I'll come back to you on an issue. One of the issues around the Irish National Orthopaedic Registry, and if we're going to be having patients treated in the private hospitals, how do you see the likes of INOR and the importance of INOR and clinical audit being part of that?
So it's a very good point. The INOR, the National Joint Register, tracks all patients that have their joints done, well, almost all in the public service, and we have been making roads into the private service, but unfortunately none of the private hospitals are yet aligned with the National Joint Register. And yet, because of the crisis, some patients who are logged into the National Joint Register are having their operations done in private hospitals which don't have access to the National Joint Register. So I spoke to Suzanne Rowley yesterday, and she's the national lead, the national director for the National Joint Register. And she tells me that because there'll probably not be that many patients getting their joints done in private hospitals, that we will be resorting to a paper-based system for those patients. As many may know, the National Joint Register is a fully electronic system, and that's the way we collect data. If the hospitals aren't aligned with that, they can't do that. So for a short period of time, hopefully, and for a few patients, we will be going back to an old-fashioned paper-based system.
Yeah. And I don't know, Brian or Debbie as well, I mean, clinical audit is going to be a vital component of assuring quality, and there's a great, an opportunity really to kind of get that across the whole system right now, isn't there?
Can you hear me?
Yes.
Is that better?
Yes, Brian, we can hear you now. Thanks. Yeah.
Sure. Again, just going to try again, reference the previous question about nursing. I think, as I referenced, there's going to be a huge repatriation of nurses from the critical care surge back to the theatre complex. But I'm just urging a note of caution, because whilst the RCI have documented the increase in need based on the recent document in terms of surgical need, there will potentially be at the same time a surge within the critical care and cases of COVID cases coming to the actual hospitals. So we need to be careful about how we do this. As I referenced, I think there's potential for increased activity on the COVID and on the non-COVID side, which will produce certain challenges.
Thanks, Brian. Brian, we also mentioned, I think, and it's something that we've had a number of questions in on, one that I'm struggling with this challenge ourselves is our training programs. And I think many of us, many people on the call here and our presenters tonight are all trainers. And the issue of the lack of activity certainly is a concern for our trainees and logbooks and skills. Just wondering, any kind of ideas or approaches you think that would be good advice to our trainees right now on how they should be dealing with this? So,
yeah, it's been a very difficult piece, that, and I think what we've tried to do, of course, is there is a certain amount of urgent and sort of time-sensitive surgery happening. So, for example, within I work in Galway University Hospital, and the cardiothoracic program has now been moved to the Galway Clinic. So we are trying as far as possible to send or fulfill their training. Our trainees are now being moved to the COVID ICUs. We have communicated with them. We have said that we would be liberal in our interpretation modular training elements during the COVID pandemic, that this would be, and we would be fairly liberal in terms of
again, sorry, Brian, unfortunately that connection is very poor at the moment. Brian, sorry there, your connection unfortunately is very, very poor. I might ask, Debbie, if you were talking to your trainees, what would you be saying to them right now?
Well, I think it very much depends on what stage they're at. This is a difficult time for everyone in training and in practice, and I think we have to be as flexible as we possibly can, help them develop their skills within the opportunities that we have, encourage them to study and do their exams. in Beaumont, one of my colleagues, David Carney, has set up a virtual journal club. We're going to have our first meeting tomorrow morning. So those sort of activities are really useful to help trainees. But I think ultimately, when it comes to things like logbooks, when it comes to training, it's possible that people will need some more experience. We need to be as flexible and, as helpful to them as we can. And I think we have to give them some optimism and hope for the future. This is a really difficult time, and it's going to be with us for probably a number of years, but we will get through this, and we need to encourage our trainees to look over the 30 years of their careers, not just the next 30 months.
Thanks for that. Great words there, Wisdom. Paddy, do you want to say anything on the training side?
Just as Debbie said, it's a very difficult time for the trainees. Our monthly core curriculum, which is directed by Rory McNichol, is still ongoing. It's all online like this. The trainees are finding it useful, but of course it's not the same thing as a proper core curriculum meeting. We have journal clubs online, we have teaching sessions online, but it's very difficult for them, and in particular for the trainees who are in the hospitals where the ICUs are full of COVID patients. They're not getting any surgery to do, and that is they're very frustrated.
So, I mean, I think, look, it is a moment in time, and I know the colleges, the 4 colleges in Ireland and the UK, it's the same issue all over the world, to be honest. But in Ireland and the UK, it's well understood by the SACs, the Joint Colleges Surgical Training Committee, our own training college as well, and we're looking at this area. I think it must be seen as very optimistic if trainees are listening to these talks tonight, that there are huge efforts being made to get activity back in action, and hopefully that we will see a lot of work coming back into the theatres, and that will help them. And we're also quite lucky as well, I think, that many of our programs are their curriculum are so well defined now that we can look at competencies, we can look at ways that we're not going to over penalise people in terms of the logbook activity, because there are other ways they have been learning and developing their career for the last number of years and so on. So it's an ongoing area, and certainly we'll be as supportive as we possibly can to everybody in training on that. So I'm going to, I know we're heading towards 7:20, and we've generally gone around this sort of time. I'm going to ask our president to come in here on this one, perhaps, because it's kind of quite an interesting kind of comment and a general question that's come in, that given the current kind of crisis that we have, and that it's asking us rethink all of how our services work, is this time to really look at the overall reorganization of surgical services? And we heard where dedicated scheduled surgical hospitals should possibly be the way forward. And indeed, in the COVID sort of situation, there was a comment come in on the chat around COVID dedicated hospitals or centres or hubs to look after COVID patients and so on. So what would your thoughts be, Ken, on the opportunity perhaps to think of reconfiguration?
Thanks, Kieran. I guess it's fair to say that sláinte care hasn't gone away, and I think those involved in sláinte care are still working in the background. I know work is still being done in terms of trying to build the modelling supporting the three national elective hospitals that were mentioned in the national report attached to sláinte care. So I don't know, but I suspect that the Department of Health will be looking at what's happening during this period and seeing, can any of the activity and the rearranging of services be included in the sláinte care planning. And I think we do have to take some solace from the fact that perhaps we will get our elective hospitals sooner rather than we thought. We may find money for ambulatory care centres, which clearly would protect, if you consider that 80% plus of all elective planned surgery is ambulatory care, it's day case type surgery. So perhaps some of these things will happen sooner than we had planned, and I think that's for the good. Yeah.
Great. Well, thanks for that. So I think at this stage we've managed to cover, I think, most of the comments and questions are in there. I don't know, does any of the speakers want to say any last few words, or all okay? Well, look, I want to just bring it to a close and to say thanks again to all of the team in Surgical Affairs for supporting the webinar, and particularly thank all of our speakers tonight, the President of the College of Anesthesiology, Brian Kinnerans. Thank you, Brian. For Paddy Kenny and Debbie McNamara, our national leads in the national clinical programs, for presenting tonight, and as always our president for giving us an update. So on that, I just want to wish everybody a very good night. Thanks for tuning in. We'll be having another webinar next Wednesday as normal. Any of the documents that were referenced have been put up on the chat. They're all available on our website, and I refer everybody to the RCSI COVID update website, and indeed Surgery for on the training side of things. And to just everybody to stay safe, and wish you all a very good bank holiday weekend if you can get some time off. Thank you. Bye.